Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Tim Quill. Today's episode features Dr. George Demetri of the Dana-Farber Cancer Institute in Harvard Medical School in Boston, Massachusetts, and Dr. Alexander Drilon of the Memorial Sloan Kettering Cancer Center in New York City. They will be discussing the underlying rationale for and clinical strategies to test for NTRK gene fusions in patients with solid tumors. This episode is part of a larger educational program titled The Expanding Clinical Application of TRK Inhibitors in Cancer Care, a podcast series. For more information on Dr. Demetri and Dr. Drilon, along with a link to the complete program, including a downloadable slide set covering the content of this podcast, please visit the show notes for this episode. Now let's get started and hear what the experts have to say.
Hi, I'm Dr. George Demetri. I'm a professor at Dana-Farber in Boston.
Hi there, I'm Alex Drilon. I'm the chief of the Early Drug Development Service at Memorial Sloan Kettering Cancer Center in New York.
And together we're going to discuss some of the rationale for testing for NTRK fusions in patients with cancer.
Yeah, this will be fun, George. So let's kick it off with a few questions. Let's tell the listeners what the biologic role of TRK is in the wild type state.
And the reason we care about this is obviously because it's important we understand this target so that we can treat it when it's abnormal and fused. It forms a chimera in many types of cancers, and you'll hear about that. But first, we can understand the normal biology, because for years, people stayed away from NTRK genes or TRK proteins just because they were worried it would be too toxic to drug. These genes and proteins are important in the development of the nervous system, mainly central, but also to some extent peripheral. And they have roles in development of humans and vertebrates in general and other nervous system functions. Now, just to make it curious and complicated, the genes come with numbers, NTRK1, NTRK2, NTRK3, but the proteins come with letters, TRK-A, TRK-B, and TRK-C, conveniently in order, thankfully. And the bottom line on these is that these genes get translated into proteins that have functions in even adults of things like management of thermoregulation or proprioception and balance or pain. And interestingly, for TRK-B, appetite and weight, as well as a little bit of mood and even possibly memory. So these targets were stayed away from in drug development era for a long time, even though fusions were known about since the late 1980s in biolabs.
And that's exactly why it's important to keep these in mind, George, because later on in the second episode, we're going to get to how patients feel when they get an inhibitor of TRK. And so keeping in mind that these pathways control balance and appetite, that'll come back to our discussion later on. But perhaps now let's move into cancer, oncogenesis, and what role these NTRK genes play in the development of cancer.
We certainly know that many cancers are driven by gene fusions. All you have to do is think about chronic myeloid leukemia, and then you fast forward and you're in other fusions like ALK fusions or ROS1 fusions or RET fusions. Many oncogenic genes lose regulation by fusing to another gene. And that's certainly true with the TRK genes, any of them, NTRK1, NTRK2, or NTRK3. If they pair with some other gene, and they can pair with many other genes, it doesn't even matter what the partner is, they lose regulation. They turn overactivated, and that stimulates the cancer growth and maintenance.
And just because our listeners are probably familiar with other mechanisms of oncogenesis, an important question, I think, and this goes to interpreting a patient's report perhaps, is whether or not other oncogenic states such as mutations or copy number changes like amplification, is that relevant to the NTRK genes and how they cause cancer?
It's super relevant because so far the TRK inhibitor drugs are absolute breakthroughs, very important therapeutically for people with NTRK fusions, or if you're talking about the protein, TRK fusions. And if it produces a chimeric TRK fusion, a chimera that's oncogenic, the TRK inhibitor drugs are terrific therapeutic agents. If they're activated through a single point mutation or a small deletion or even potentially amplification, we have not seen the same level of clinical activity. And that's really important for practicing clinicians to understand. The fusion is druggable and very important to find. The point mutations with current knowledge do not respond to these drugs. It's not a failure of the drug. It's just not a therapy for that patient. They're only approved for the fusion patients as well. So it is important to read carefully what's in a molecular genetics report. Also importantly, you might see something that says NTRK rearranged. Now, not all rearrangements are fused. We're trying to get this in the minds of the pathologists, the molecular pathology reporters, to say, is this a productive fusion? Do you actually see an NTRK gene fused to something else? Or is it simply broken apart into a million pieces and rearranged in a noisy genome of a cancer cell? That's a really important thing for practicing clinicians to understand in reading these reports.
And I think equally important, you mentioned this, is the fact that perhaps the number of mutations that we see in NTRK 1, 2, and 3 is higher than the number of fusions we might find. So it's not an uncommon situation. You'll find a report with NTRK something.
We see that all the time. And it gets the doctor all excited for a nanosecond until they say, oh, that's just a point mutation. That's not a fusion. So I can't use one of these terrific new drugs.
That's right. And it brings us to the next question. How common actually are these fusions? And are there buckets, when you think about frequency, that group patients into certain classes, if you will?
And that's a key thing. Alex, you're at Memorial, I'm at Dana-Farber. We're at these quaternary care referral centers. For us, rare tumors are frequently referred. So for my world in sarcoma at Dana-Farber, we actually see a fair number of TRK fusions because in many types of sarcomas, especially infantile fibrosarcoma on our pediatric side, this is essentially a pathognomonic driver. We've known for years that the fusion of NTRK genes is essentially pathognomonic for that very unusual pediatric cancer. But we see a lot of that pediatric cancer as a referral center. Now, if you're talking about things like common diseases like lung cancer, which is your specialty, Alex, how common is it? How often do you see TRK fusions in lung cancers?
Oh, it's almost the opposite. It's found in much less than 1% of cases. In fact, the series that we did that looked at prospective sequencing found a frequency of 0.23%. But the issue there is that you're not only looking for these NTRK fusions because lung cancers are enriched for other actionable alterations. We actually test for many of these that were mentioned earlier: ALK, RET, ROS1 fusions, EGFR mutations. But it certainly is one other thing to interrogate when we look at sequencing our patients' cancers.
But I think that's really important to emphasize. The non-small cell lung cancer community has been the early adopter of molecular testing, mainly because you've got a lot of very important genes. You need to know what they are to take care of that patient. You just named a list of them. So you really are already getting multiplex or several gene testing when you're going to get tumor genomics. I think the rest of the solid tumor world hasn't caught up on that, and that's going to be a challenge for us. How do we find these TRK fusions? We're trying to put in place some way of saying, here's an enriched population. I already told you infantile fibrosarcoma is one of those, and very weird forms of salivary gland cancer like mammary analog secretory carcinoma. Like, who sees those? Yes, the head and neck specialists. But some doctors see them, and I would hate to see one of those missed. So that's one where it's almost pathognomonic, as well as the secretory subtype of breast carcinoma. But there's no histopathologic differentiator for lung cancer or for pancreas cancer or for colorectal cancer or even for sarcomas that would tell you there's an NTRK fusion hiding in that cancer. And that's important for people to understand. Let me just mention my favorite disease of gastrointestinal stromal tumor, or GIST. What's clear here is that if you've identified a KIT mutation or a PDGF receptor alpha mutation or an SDH subunit mutation, you don't need to look for a TRK fusion. But importantly, if the GIST in front of you has none of those mutations, that's where these TRK fusions might be hiding, even in the GIST world. But again, why test one gene at a time increasingly for diseases like GIST or certainly for non-small cell lung cancer? We're seeing more multiplexed or many gene testing be the optimal standard of care.
Yeah, and we see that paradigm across other cancers where there might be a couple of things that you're looking for. Certainly, if you do sequential testing, it wastes a lot of tissue and patients can undergo multiple biopsies, which we're trying to avoid. Let's go to how to actually identify these fusions. NTRK diagnostics. What's your test of choice, and does the environment that you practice in, George, dictate what you might reach for?
I'm sure the environment we practice in makes an impact on many decisions. Our pathologists are so good. They say, why do you need molecular testing? Because they can tell different subtypes just by looking at them. And I'm pushing back a little bit to say, you know what? This is one, you can't do that. You really cannot tell what's driving that sarcoma, and we need molecular testing. Now, they'll also push back and say, well, we certainly know that we haven't seen this in a sarcoma of this type. But there's always a first time. For a long time, I was concerned that liposarcomas, another weird type of sarcoma, have other drivers like MDM2 amplification, CDK4 amplification. But a series out of France found 3 liposarcomas with TRK fusions. And this were at expert centers in Lyon and Paris. So again, I think we're learning a lot about NTRK fusions. And the answer is, especially in rare diseases, there's no substitute for molecular testing. Now, if you don't have access to molecular testing, which is an issue in many parts of the world, there are pan-TRK immunohistochemical staining techniques. You could use an antibody and just look for TRK expression, because most normal adult tissues do not have TRK expression. It's not a perfect test, though, because, again, if you've got some peripheral nervous system tissues in there, they might have a little bit of TRK staining. And again, in my world, malignant peripheral nerve sheath tumors can have a little TRK expression. So that can be a confusing factor. You need the molecular diagnostics anyways to distinguish that. I don't think we as a community of doctors and experts and pathologists have figured out an optimal way of doing this. And certainly Memorial Sloan Kettering and Dana-Farber have been at the cutting edge of trying to push genomic testing into a standard of practice. But I recognize that in the community, it's sometimes a controversy.
Yeah, and I've seen that as well at our centers or other centers in the country that have access to next generation sequencing. That seems to be a preferred method to finding these fusions. While at other centers, I'm from the Philippines originally, and certainly other centers in Asia where there isn't coverage, payer coverage for next generation sequencing, and something like immunohistochemistry, which is much, much cheaper, might be used as a screening tool with, what we say orthogonal or subsequent confirmatory testing to make sure that an NTRK fusion is there. There's, for those centers, George, where next generation sequencing is available, there is some data, though, on whether or not it's important to do an RNA pass after you've looked perhaps only at DNA. Do you want to talk about that a little bit?
Yeah, it's true. RNA testing, and again, next generation sequencing, when are we going to call that current generation sequencing too? It's been next for years. So I think what we still call next generation sequencing could be done on DNA or it could be done on RNA. And it's much more sensitive if you look at the RNA. On the other hand, if we're still trying to talk people into getting comfortable with DNA testing, which is much more stable and the testing's easier to do, in many ways, I'd be happy with a DNA screen, and only if I have a very high suspicion that there might be something hiding in there would I do the RNA testing. I know Memorial adopted the RNA testing as a standard earlier than we did. Maybe you could talk about your experience with that.
Yeah. So we've done it for cases that are DNA next generation sequencing negative. And the bulk of our experience has been, again, in the lung cancer world, where we certainly find a variety of fusions, including NTRK 1, 2, and 3 in cancers that were deemed to be quote unquote driver negative by DNA-based testing. So there are also commercial companies that have worked in an RNA pass. either concurrently or when they process the tissue, or perhaps in a staged or sequential manner. But it's just something to keep in the back of your mind, especially if you might be dealing with one of these histologies where it's almost pathognomonic, have a fusion, and somehow you don't find something. If you're suspicious that you're missing something, RNA might be the way to go. And perhaps to end this section, George, what are your thoughts on liquid biopsies?
Again, I'm biased because I'm in the sarcoma world, and sarcomas do not shed a lot of circulating tumor DNA into the bloodstream. I'm very jealous of you as a lung cancer person because lung carcinomas shed tons of circulating tumor DNA. So I think the sensitivity of that assay in my world of sarcomas is much less than it is for colon cancers or for lung cancers. Have you used that successfully?
We have. So as you mentioned, we use it a lot in the lung world. And I think the punchline boils down to what you just mentioned, sensitivity. So if you find something, if we find an NTRK fusion in plasma circulating tumor DNA, we would trust it and use it to treat someone with targeted therapy, which we'll discuss later. However, if you don't find anything, it doesn't mean that there's no oncogenic driver in someone's cancer. It may be an issue of shedding, and it's just not the best test to say there's absolutely no driver in someone's cancer.
I think you said that very well, and I've yet to see one of the circulating tumor DNA companies be honest about that and say a negative is not negative. A negative is simply uninformative. You just can't tell. But a positive, generally, I agree, you can rely upon that. And I think lung cancer has really led the way in that.
Well, this was very informative, George. Thanks so much. We'll bring this session to a close.
Thanks, Alex. Pleasure talking with you.
Thank you very much, Dr. Demetri and Dr. Drilon, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, The Expanding Clinical Application of TRK Inhibitors in Cancer Care, a podcast series, and to download the slide set associated with this discussion from the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.